A 70-year-old male was referred to us for evaluation of etiology of obstructive jaundice. Patient has severe icterus and severe cholestatic symptoms, and with 15% ejection fraction, very poor risk for surgical procedures, and therefore was evaluated with endoscopic ultrasound. Here we can see the bile duct coming down. There is a mass lesion in the upper CBD region. That's a portal vein. You can see the hepatic artery, the pancreatic duct coming into the ampulla of water. A careful evaluation of lower CBD was first carried out, and we can see some hyperechoic echogenic artifacts at the lower end of the CBD and the MPD. This could be a diverticulum, duodenal diverticulum, either an intradiverticular ampulla or a perivertarian diverticulum. This is important for endosonographers to keep in mind when they are evaluating the absolute lower end, especially when the bile duct and the pancreatic duct is opening on the edge of a diverticulum. Here you can see where my arrow is pointing, hypoechoic lesion in the bile duct, probably a cholangiocarcinoma. You can see the part of the tumor, and now you can see the gallbladder with imaging microliths and some sludge. You can see some cholesterosis changes. Again, you are seeing the tumor in the bile duct, lower CBD up to the ampulla. So careful evaluation of gallbladder is being done. We are gently withdrawing the scope and evaluating the part of the bile duct from the stomach now. So from stomach we can evaluate the pancreas, the celiac artery. There are no lymph nodes, no evidence of lymph nodes in the supradiaphragmatic posterior mediastinum either. We can see dilated left hepatic ductal system. This signifies common hepatic duct involvement. There are no obvious hypoechoic or lesions seen in the left lobe of liver, which we can also see in malignant lesions. So a very effective evaluation of the mediastinum, lymph nodes, and left lobe can be done. Now with linear echoendoscopy, we are trying to obtain some tissue for diagnosis. As you can see, duodenal approach may become extremely tricky purely because of the location of the lesion, and since we have been referred this patient purely for diagnosis and definitive palliation as surgery is ruled out, we may have access to this lesion from transgastric route, and that's exactly what we may plan to do. So you can see here there is a lesion seen from the stomach, dilated system. We are chasing the left hepatic duct up to the common hepatic duct. That's a technique which we employ. Here you see dilated IHBR in the left ductal system, and I'm trying to rotate my scope clockwise and try and get into the position to see the hypoechoic lesion affecting the common hepatic duct region. Now you can see the common hepatic duct area where you can see the lesion, and transgastric route. We are doing EUS guided FNA. We prefer to use a 25 gauge needle usually for this kind of interventions, as we can get a fairly good amount of material for cytological examination. So whenever we have a patient who has definite indication for only palliation and not resection, we prefer a transgastric approach for tissue acquisition, as seen in this particular case. So you can see very gentle maneuver, very gentle aspiration, no jiggling movements within the lesion. We have gentle movements here, and maybe couple of passes, and we'll have adequate tissue for examination. Immediately after EUSFNA, we proceeded with ERCP. We wanted to palliate this particular patient with a deep icterus and cholestatic symptoms. Despite several attempts, as you can see here, we were not able to cannulate the bile duct very easily. So there is an intradiverticular ampulla with a periverterian diverticulum present. So this is a tricky situation to handle in difficult ERCP with a difficult stricture. So we managed to put a wire in the pancreatic duct, as you can see here. What we are putting is a 0.018 wire, a very, very small wire we were able to put in the pancreatic duct. So what we are securing is pancreatic orifice, because this is an obstruction purely in the bile duct, so pancreas can react. You can see the intradiverticular ampulla and the periverterian diverticulum at the same time. So it was important for us to first secure the pancreatic duct with a 3 French stent. You can see here we have placed the 3 French stent, and subsequently we will now try and cannulate the bile duct if we can at the same time. But despite a couple of attempts, as you can see here, we were not able to get into the bile duct very easily, and therefore it's a policy at our unit, once we have secured the pancreatic duct, even though it is intradiverticular ampulla or even with periverterian diverticulum, we will proceed with needle knife pre-cut sphincterotomy from top down. As you can see here, we are cutting over the roof of the ampulla, exposing the biliary orifice, which is cranial, in this case slightly to the right of the pancreatic duct orifice, and you can see that we have cannulated on fluoroscopy into the bile duct. Now, because of the tightness of the stricture, the wire somehow is not able to go across, so we are able to put a sphincterotome over a guide wire, and we will first do a biliary sphincterotomy here in order to advance other equipment and accessories to facilitate our passage across the biliary stricture into the left hepatic ductal system. That's our target of procedure this time, because we have a fair degree of idea on EUS. So now with a catheter, we are trying to put a terumo, and as you can see, with some maneuver, we are able to cross the stricture and go into the left hepatic duct. Our catheter with push, a tapered catheter of 6 French, was able to pass, and you can see an air cholangiogram, which is showing an independent block of the left ductal system. Minimal contrast was used, and which shows the left ductal system independently blocked, and therefore we planned to drain only one system in this particular case, as one metal stent would suffice for this ductal system, and will probably comprise more than 30% of liver to be drained. So once we have placed the guide wire, terumo, and through that we place a catheter and then change a stiffer wire here, and we are now putting a brush cytology catheter. After brushing, we plan to do some balloon dilatation. Is a standard practice at our unit to dilate stricture, biliary stricture with balloons. We started with a 4 millimeter balloon, but because of the sclerotic nature of the stricture, it was almost impossible to go with a balloon. So we are retrieving the balloon, and now we are trying to put a 7 French Sohendra dilator, a tapered one. If we can get across with a dilator into the stricture, that will allow our subsequent procedure easier. But you can see here, despite all our maneuvers on fluoroscopy, up and down and all kinds of maneuver, we were not able to go across this sclerotic fibrotic stricture at the common hepatic duct. So we resorted to using 10 French Sohendra retriever, and as you can see, I'm going through the stricture in a clockwise rotational movement and elevator. We were able to go across this very, very tight stricture leading to independent block of the left ductal system. So after the retriever dilatation of the stricture, we decided to go ahead and deploy uncovered self-expandable metal stent. This case is a 7.2 centimeter uncovered stent from Ella. We are deploying the stent, as you can see, in such tight strictures. We have seen that this kind of stent delivery system opens up fairly easily. As you can see here, the stent is being deployed, and under fluoroscopy control we can see that optimal stent deployment is achieved. The contrast appears to have drained, and this is the end of the procedure.